Shun. I'll tell you about a clinical case which lasted for over 10 years. The patient, Mr. Chen, a 70-year-old male, complained of repeat ulceration and suppuration in his left foot for more than 10 years. He was diagnosed with eczema, however, the treatment was highly effective. Finally, he visited our hospital. Dermatological examination revealed multiple dark red warty plaques in the lower quarter of the left calf, the dorsum of the foot, the ankle, and the heel, which were hard in texture between 1 cm by 2 cm and 5 cm by 6 cm in size, and the rashes were chiefly covered with thin layers of yellowish red crust. There were muscles in the local lesions, with evident melanin deposition and depigmentation. This case gives us a mystery. What is the cause? Pheohyphomycosis, tuberculosis varicose acutus, squamous cell carcinoma, eczema. The dermatologist prescribed detection of bacteria and fungi and smears. As the proverb goes, Rome wasn't built in a day. He may have had a chronic fungal infection. He was a worker and a peasant. As we know, in the southern provinces, peasants often work barefoot in the fields. Samples were collected from multiple locations of the lesion and detected by wet wound slide, gram staining, fluorescent staining, and acid-fast staining. Paradoxically, no pathogens were identified. Isn't it a fungal infection? Ruling out fungal infection needs meticulous examination and differentiation. So, we proactively consulted the dermatologist for advice. The dermatologist postulated the possibility of fungal infection or squamous cell carcinoma. After we communicated with the clinicians, in addition to delivery of tissue sections for pathological diagnosis, we retained the piece of tissue in our laboratory for further detection. Hard work pays off. Ellipsoidal, separated, thin-wall spores can be seen macroscopically. After literature retrieval and comprehensive discussion with the dermatologist, we postulated the sclerotic body was in fact a critical marker in chromoblastomycosis. 5 days later, the pathological results showed that a small number of fungal spores was locally visible, which was consistent with fungal infection. Here, in the 2 pictures, we can see pseudoepitheliomatous hyperplasia and inflammatory cell infiltration. We waited and waited. Finally, after 5 days of culture, the colony became black and fluffy. The spawn-forming structure of Cladosporium and the Rhinocladiella tab appeared. But what is the culprit's name? Mass spectrometry identification was employed, and the result was Franciscia monofora. For further verification, signal sequencing was performed with similarity of 98.5% to Franciscia monofora, but it is hard to distinguish from Franciscia penjosoi. For the evolutionary tree construction demonstrated 99% similarity to Franciscia monofora. With the combination of morphology, mass spectrometry, and molecular detection, the pathogen was finally identified as Franciscia monofora. According to the diagnostic criteria of mycosis, in combination with clinical, microbiological, and pathological factors, Mr. Chen was diagnosed with chromoblastomycosis caused by Franciscia monofora in the left foot. With the diagnosis, the regimen for Mr. Chen was constituted, namely itraconazole, terbinafine hydrochloride tablets, thymosin, and the transfer factor, local hot bath, ointment, and carbon dioxide laser fractionated treatments. After 6 months of treatment, Mr. Chen recovered. From the diagnosis and treatment of this case, timely and accurate diagnosis of chromoblastomycosis is essential. Meanwhile, high-quality specimen collection and the proficiency of clinical laboratory technicians are indispensable, plus effective communication, cooperation, and coordination with the clinicians. In the encounter with rare fungal diseases, the case we share is just the tip of the iceberg. Our battle against the pathogens keeps going. Only by the effort and cooperation with all medical professionals can rare pathogens, especially fungi, have nowhere to conceal. This is the end of my case sharing. Thank you.